All right, so this evening we're going to be discussing what bariatric surgery is, who can benefit from it, and the different procedures available to help you lose weight and improve your overall health and well-being. So I'd like to start by introducing tonight's speaker, Dr. Isam Hamdallah, a bariatric surgeon who is part of the Ascension St. Agnes bariatric surgery team, along with Dr. Katrina Swift. Dr. Hamdallah has been practicing as a bariatric, minimally invasive, and general surgeon in Baltimore since 2011. He performs a variety of minimally invasive procedures, including lap hernia repairs, reflux surgeries, as well as bariatric procedures. He is also active as a clinical educator and teaches surgical residents at Ascension St. Agnes and previously instructed Howard University residents at Northwest Hospital. Dr. Hamdallah is proud of the volunteer work he has done for Operation Smile in Jordan, as well as the laparoscopic procedures for those in need in Jordan as well. Thanks for joining us tonight, Dr. Hamdallah. We're happy to have you.
Thank you, Kelly, for the kind introduction, and thank you for facilitating this webinar tonight. I hope our audience find it exciting and informative. We're going to go ahead and discuss obesity as a disease, bariatric surgery as an option, and what to expect with the whole process. And hopefully you'll find answers to a lot of the questions that you're thinking of and considering. Obesity is a complex disease, and although it's very easy to say it's a disease, it's a very complex disease, and that's a problem. It took us a while as a medical society to get all parties to agree the definition that obesity is a disease and it's a chronic disease that needs to be tackled. It wasn't until 2007 that obesity was diagnosed as such, and everybody agreed on that. So up until then, obesity was considered as a condition, but not as a disease. We know that it leads to much suffering. We know it contributes to ill health, functional impairment. Most important, it reduces quality of life and can increase mortality and dying at a younger age. Successful treatment, although it is difficult to achieve, it produces many benefits and reverses a lot of the negative effects of obesity. In the US, at 2018, more than 73% of Americans were at least considered overweight, and 42% were considered obese, with almost 9% considered severely obese. And although obesity is not well defined, we know that it is an abnormal or excessive fat accumulation in the body that leads to risk to health. We know that there is a calculation we rely on. We call it BMI, or body mass index. And that's pretty much, it's a ratio between the weight and the height. Because different heights, you can consider that someone, for example, might be shorter. They need less excessive weight to lead to the same medical conditions that someone who is taller with that same amount of weight. Now, we look at it that a healthy BMI is when it is under 25, but truly the medical conditions start appearing when patients have a BMI more than 30. And more, as the BMI increases, the medical conditions can increase in severity and in presence. We consider severe obesity when the BMI is over 50, but anything over 40 is going to reduce the quality years of life pretty much. Overall, when you look at that calculation of the BMI, it ends up correlating to about 100 pounds over the ideal body weight. There are many causes to obesity, and although a lot of people think that it is only about large portion sizes of food, that is actually only one of the factors, and it's not always the case. A bigger role is because of the processed food that we consume. There's also lack of fresh produce. There is limited physical activity, whether it is because of work habits, the lifestyle. There is an increase in use of food as a coping mechanism sometimes. There's adaptive traits. There's also psychological factors that can play into it. But now we're realizing more and more that there are huge roles for genetics, for gut microbiome even, and for hormone imbalances. Even certain antibiotic uses can lead to increase in obesity. So why do we need to treat obesity? It's because each increase in the BMI can lead to increase in mortality. That is the bottom line. And when they did the math and the calculations and they did the studies, they found that about each 5-point increase in BMI over the 25, which we're going to consider here as the ideal BMI, is associated with a 30% increase in all-cause mortality. Now, we tend to start seeing an improvement in the medical conditions and in all-cause mortality once the patient starts losing more than 10% of the excess body weight. There are over 86 known conditions that are caused or worsened by obesity. And when you think about the number, you're going to realize that obesity is all the way up there as one of the commonest reasons that can cause medical conditions. One of the ones that I want to talk about is diabetes. Diabetes is a big problem. It's a big problem that faces us as a society. And the problem is that the incidence of diabetes is on the rise. Diabetes on the long term can lead to nerve damage. It can lead to renal failure, gastroparesis, blindness. It can increase risk of cardiac events, risk of strokes, and the list goes on and on. But we did notice that after bariatric surgery, there is excellent remission in patients with diabetes and improvement. Even with the sleeve gastrectomy, there is increased improvement with diabetes resolution. And the percentages of resolution of diabetes or improvement, it all depends on several factors. For example, what is the duration of diabetes? Someone who's been diagnosed with diabetes over the last 2 years, we expect them to resolve the condition in excess of 90-95% of the time. Someone who is using only an oral medication for diabetes will see greater improvement in their diabetes profile after weight loss than someone who is on several medications, including insulin and ANTA. So the improvement in the glycemic control and the diabetes control differs, but overall, we've noticed excellent improvement. Cardiac situation also deteriorates with obesity, whether it is through increase in patients suffering with high blood pressure or high cholesterol levels and triglycerides. Even the risk of heart attacks, strokes, and heart failure increases as the patient becomes more obese. But we did notice that patients who undergo bariatric procedures and lose significant amount of weight, the risk of cardiac death drops by 50%. Also, the risk of stroke over 2 to 3 year studies have been shown to decrease. High blood pressure or hypertension resolves in more than 2/3 of the patients. Cholesterol and hyperlipidemia also improves in almost 2/3 of the patients. Respiratory problems, one of the commonest problems nowadays we're diagnosing and we're seeing is obstructive sleep apnea. And some patients that presents with them as severe loud snoring. But more important than the snoring, it's truly the interruption in breathing while the patient is asleep. So it's not just about the snoring, it's also about the interruption in breathing. So patients truly become apneic for periods of time repeatedly during their sleep cycle. And that can lead to several problems, including right heart failure, pulmonary hypertension. All these can be severe problems. And as you're aware, a lot of patients who have sleep apnea might need a CPAP machine, which helps them through the night so as to maintain their oxygen saturation. We've noticed that with bariatric surgery, almost 85% of patients who have obstructive sleep apnea, their apnea resolves and goes away pretty much. There are also other conditions such as obesity hyperventilation syndrome and COPD. All of these improve. And, unfortunately, we also noticed when the pandemic, the COVID-19 happened, that patients who suffer with obesity, their risk of having severe form of the COVID-19 was much worse than someone who didn't suffer with severe obesity. So unfortunately, it also puts patients at higher risk for respiratory failure and requiring ventilatory support when these conditions arise. Another problem that we've seen with obesity is osteoarthritis, whether it is degenerative osteoarthritis of the knees or of the hips. And we've noticed that once the patients start losing weight, there's huge improvement in the functions of the knees and the hips. A lot of patients tell me that their back pain resolved, their knee pain has improved, their hip pain has improved. So all these problems decrease pretty much. We estimate that every pound that you gain is almost equivalent to 3 pounds of force on the knees, hips, and ankles. And that's why patients see that huge improvement with the pain, especially over the knees and the hips, once they start losing weight. And other conditions such as neuropathy or pseudotumor cerebri or fibromyalgia, we've noticed some improvement with all these conditions as the patients lose weight. Reflux is another common problem, and by reflux, most of the time it presents as heartburn, but sometimes it can present with food refluxing, and it can happen even overnight, where patients, unfortunately, it can lead to aspiration and pulmonary infections. And we've noticed that a lot of these patients who suffer with reflux might have hiatal hernias, and that's something that we tend to fix and repair at the same time when we do the bariatric procedure. Gastric bypass is by far the best surgical option for a patient who suffers with reflux. We've seen, honestly, like resolution of more than 95% of reflux when patients undergo gastric bypass. Fatty liver is another problem you might have heard about. Unfortunately, fatty liver occurrence is very common in patients who have obesity. Fatty liver, it literally means that fat starts getting embedded in the liver itself. But the problem is that the liver starts going into an inflammatory phase secondary to that fat that can lead to scarring in the liver. And you go back 20 years ago, we used to consider it as a benign process. All right, there's some fat in the liver, it's not a big deal. Unfortunately, it turns out it is a big deal. And currently, it is the #1 cause leading to liver cirrhosis. And patients requiring liver transplant, it has superseded even like the hepatocellular carcinoma, and it is even now a commoner cause for cirrhosis than alcoholic hepatitis or drug-induced hepatitis or all these conditions. The good news is that when patients undergo weight loss procedures and they start losing weight, we see remarkable improvement in the liver profile. And majority of the time, we see that the fatty infiltration subsides within just 10% of the weight loss. So that's good news. PCOS, polycystic ovary syndrome, is unfortunately a common syndrome that we see in young ladies, and that can lead to infertility. And it is associated with increased insulin resistance, so it also can lead to diabetes in the future. But the good news is that we noticed that with the weight loss, there's excellent improvement in the polycystic ovary syndrome. There is increase in the fertility. So we see a lot of the young ladies who are suffering with infertility, and after they undergo the procedure and they start losing the weight, the fertility profile increases. We still ask ladies not to get pregnant the first year and a half after the surgery, because, that period of time, you want to focus on the weight loss, not the pregnancy. But after that, pregnancy should be fine. And we've also noticed that later on, there's reduced risk of preeclampsia or hypertension in pregnancy, and even gestational diabetes and all these conditions. Cancers. One of the surprising things back in the 80s was when they discovered that obesity can increase the risk of cancers. And currently, there is a list of more than 17 different cancers that their risk increases with obesity. You might have heard of esophageal cancer, endometrial cancer, ovarian cancer, breast cancer, even colon cancer. All these cancers, the risk increases when the patient is obese. The good news is that as the patient loses weight, the risk of that cancer, the increased risk of that cancer subsides. So just to talk a little bit about life expectancy, we expect that bariatric surgery increases an average 6.7 years to life. And patients who suffer with diabetes, when they did the calculations, they decided that it adds about 9.3 to 10 years on patient's life. But the more important part than just adding years to life is to add healthy years to life. So diet and exercise alone, although we do encourage exercise, especially exercise is very important, not just for losing weight. More important than that is honestly increasing the stamina, improving the cardiac health. That's very important with exercise. So some patients, even before undergoing the surgery, they get a bit disheartened that they're exercising, they're not losing weight. I encourage them to continue to exercise because that still is going to get them healthier and cardiac healthier. And even for the surgery, that improves the recovery from the surgery, from the anesthesia. So there's big benefits to exercise. But unfortunately, when patients use exercise alone as a way for losing weight, success is minimum. 10 to 15% of patients lose weight on the long term with exercise alone. And dieting, unfortunately, extreme dieting can get patients to lose weight, but unfortunately, the weight regain after you stop the extreme dieting is fast, and that's a problem. There's several studies that looked at surgery alone versus dieting, and of course, as you can imagine, the surgery is more superior. One thing I will also mention is the medical weight loss. I'm sure everybody has heard about the Ozempic and Wegovy and the GLP-1 agonists. All these medications rely on certain hormone, which is the GLP-1. The level of the GLP-1 during these procedures that we perform, the gastric bypass and the sleeve, increases. And that's one of the reasons why the diabetes profile improves. Now, of course, that's not the only hormonal changes after our procedures. We have the ghrelin decreases, the SGLT2 changes. So there are several hormones that their level changes after bariatric procedure. The GLP-1 agonists, they work excellent with a lot of patients. Weight loss is, it's significant, but it's still modest compared to bariatric procedures, as you can imagine. Majority of patients lose something between 40 to 50 or 60 pounds. But the bigger problem with that is that patients become dependent on these medications and they require them for life. And that's the problem, that when you interrupt the medications, you get weight regain. Sometimes it is helpful before the surgery. Sometimes we use it as combined with the surgery. But overall, the biggest improvement with weight loss and sustained weight loss on the long term is seen with the bariatric procedures. So who qualifies for a bariatric surgery? Again, as I said, when we look at the BMI, the body mass index, which is an indication that the patient is overweight and the risks of the surgery is minimal compared to the risks of not undergoing surgery and developing medical conditions. And as I said earlier, most patients, to qualify for the bariatric procedure, the BMI has to be more than 40 or more than 35 in the presence of medical conditions. And usually that translates to about, anything between 80 to 100 pounds overweight. Some of the medical conditions that qualify patients when their BMI is between 35 and 40 are hypertension, hyperlipidemia, diabetes, sleep apnea, osteoarthritis, cardiac situation. Patients who have a BMI more than 40 do not require one of these medical conditions. Just the BMI alone more than 40 qualify them for the surgical procedure. I tell patients that the surgery itself, it's going to take them a second because they're going to be under anesthesia. They're not going to be aware of the surgery. It is truly going to feel like a second. What's important is that we prepare patients for the surgical procedure so that after the surgical procedure, the recovery process is smooth and it is uneventful. And the journey, which is weight loss and maintaining the weight loss process over the years is smooth and easy. Usually the process starts with a meeting with the surgeon in the office where we discuss the path and we, personalize a plan for that patient. It also involves nutrition classes with the specialized dietitian, who's a bariatric dietitian. We also have to perform a psychological evaluation to make sure that the surgery is the right answer for the patient and there are no conditions, preventing us from being successful. And sometimes we even have to do a physician supervised weight loss. That depends on the insurance requirements. Sometimes after the visit, we might decide to do a contrast study of the stomach or an endoscopy to evaluate the stomach fitness for the surgery itself. And usually after we do the process, we do sit again and we go over the expectations after the surgery, the recovery plan, the post-operative visits. Then we move on to the operative procedure itself. The operative procedure itself, we perform it at St. Agnes Hospital. We are a bariatric surgery center of excellence. I'll be talking about the hospital and the center of excellence towards the end. After surgery, usually most patients, they stay in the hospital overnight and they go home next day. And usually I tell patients to take 2 to 3 weeks off work. Of course, it depends on your profession, but that's something that we personalize when we talk in the office. Some of my patients, their professions require more, it's more labor intense, let's say, some patients might require 4 to 6 weeks off work if they have to carry, let's say, 70 or 80 pounds when they go back to work. But majority of patients are good to go back to work within 2 weeks to 3 weeks. There's different stages for food after the surgery. We start usually with a liquid diet and protein shakes in the beginning. Then we advance it to more pureed food to give it more consistency. And then after that, we advance to soft food. And from there, we move on to regular diet. One thing I like to talk about is bariatrics, multivitamin. And multivitamins are important, especially in the bariatric patient population. And usually we require patients to take vitamins in the future. And that's something we're going to be looking at your blood work in the future. We're going to evaluate it every year to make sure that your levels are fine. And the expected weight loss is significant. Usually we go by percentages more than the numbers themselves. But I would say that we see that the majority of the weight loss will take place within the first 3 to 6 months after the surgery. I expect patients to continue to lose weight up to about 1.5 years from the time of the surgery, but the majority, about 2/3 of the weight loss, is going to happen within the first 6 months or so. Let me pause here for a second, Kelly, and see if anybody has any questions.
Perfect. Yeah, we do have a couple that have come in. To start off, could you outline what the time frame is for getting ready for surgery? Like from the time that you decide this is something that I'm interested in pursuing up till the surgery time, like roughly how long would that be?
Excellent question. So the requirements for the surgery for any patient is, of course, to meet with the surgeon, discuss the surgery. Then we have to do the dietary education. That's with the dietitian. The dietitian, Nancy Lam, she has a program. Most of it are videos. She will first meet with the patient like a Zoom call and go through a screening process. Then there are about 10 hours worth of videos that the patient will watch and questions that they will answer. And of course, that depends on the patient. Some patients, they do that within a week. Others might need a month to go through them. So it depends on the patient and your schedule. We also require the psychological evaluation. That's usually a one-time visit with the social worker or the psychologist. Usually it's about an hour visit, and most of those can be done virtual. So it's a Zoom call. So, and all these studies, upper GI, endoscopy, if we need it, if we need a cardiac evaluation, most of them are done within the first, let's say, 4 to 8 weeks, depending on the patient's timeline. Now, some insurance companies require us to show that the patient for a period of 3 months or sometimes 6 months have worked with a dietitian or their primary care physician, okay? And that is what they call the documentation. And some patients might have done medical weight loss in the past. Some patients might have worked with their primary care physician or with a dietitian, or sometimes even with Weight Watchers, where you've done the card stamping. most of these things, they qualify. We just need to present evidence to the insurance company that for a period of 6 months or 3 months, depending on the insurance plan, that the patient has done that, attempted weight loss. So, I would say if your insurance company requires that, then probably the timeline is 6 months. If they don't, then probably it's 1 to 3 months.
Perfect. Is there any risk for someone who's a little older, like maybe 55 to 65 for bariatric surgery?
55 to 65 is still acceptable range for the procedure. I can tell you that patients are considered for the surgery up to about 70, I would say, depending on the fitness of the patient for the surgery. So it is case by case. 55 is definitely still young. I would say probably more than 25% of our patients are over 55. I think the consideration with the age limitation starts when the patient is around 70 or 68. Yeah.
Okay, thank you. Would a patient need anyone to stay with them after surgery to help assist with recovery?
Excellent question. So patients are going to be up and walking 2 hours after the surgery. I always joke with my patients that I have spies on the floor. So if you're not up and walking 2 hours later, I'm going to come back and make sure we walk together. But truly, about 2, 3 hours after the surgery, most of our patients are up and walking on the floor. They're using the bathroom on their own. They're drinking, all these things. When they go home, I tell patients, make sure that you have an adult companion with you at home, especially the first night or 2 nights. Past that, not really. Like, my point is that by the time you go home, you're going to be fine going up the stairs, using the bathroom, all these things like physical requirements, you're going to be fine with it. But of course, you cannot drive, especially the first 10 days or so, or especially if you're taking pain medications. And then we're going to send you home on pain medications. So better to have someone with you. Most of the patients, when we're talking about pain, when we do the surgery, we do a nerve block in the abdominal wall. So usually pain is not a big complaint, and that's why the patients are up and walking 2 hours after the surgery.
Perfect. Thanks for that explanation. In regards to diet after the surgery, would a patient just buy regular food at the grocery store and puree it for that week, or is there a different type of food or like program that you recommend?
So actually, the food after the surgery is probably the most important thing for the patient to focus on learning about before the surgery. And that's what the dietitian, Nancy, is going to go through, thoroughly. And it's honestly the food is available, but it is which food to buy, learning how to read the food label, the caloric content, the protein content, so all these things. So I would say that it is not that you're going to be buying special food or special brand of food, but of course, which food you're going to be eating or pureeing, it all depends on, the education. But, overall, I do tell patients that at the end of the day, it is food in a blender, yeah.
Great. Does state insurance qualify for the entire before, during, after care for surgery, or what kinds of insurance programs do you accept?
So we at St. Agnes, at Ascension St. Agnes, we accept all insurances. So yeah, and I always joke about it. The best thing about the state of Maryland that it is a state mandate. So if your insurance is from Maryland, then it definitely covers bariatric surgery. And I say that because some states they do not. Like we get some patients from Virginia where there isn't a state mandate in Virginia. So some patients who come to me who work in Virginia, they might not be covered by the insurance for the bariatric surgery. So it all depends on their benefits. But almost all the insurances from the state of Maryland, they cover the bariatric surgery.
Perfect.
Yes.
Will bariatric surgery help with kidney stones?
It will not. That's an interesting question because it's not just it will not. Patients who already have had kidney stones, I want to focus more on their hydration after the surgery so as not to form kidney stones. But no, it will not. That's a separate process.
Okay.
And same thing for gallstones, stones in the gallbladder. It will not affect them. Yeah.
Okay, great. Thank you. If a patient is between lap band surgery and stomach stapling, um, is there any benefit for a lap band in terms of vitamin retention?
Honestly, lap band is a surgery that we have shied away from. And lap band was a popular procedure back in 2007 to 2010, 11, because the two most popular procedures at that point were lap band or gastric bypass. But since then, the sleeve gastrectomy or the stomach stapling has shown much better results than the lap band. So I would say that sleeve has replaced the lap band almost. Yeah. So I would definitely recommend strongly for the sleeve and against the lap band. All outcomes are much better with the sleeve than the band.
Perfect. Yeah, I know we're going to get into a little bit more on the different types of
Yeah,
procedures in the next part here. So we'll take just another question or two here, and then we'll get into that second
these
half.
are excellent questions, actually. I'm very
Yeah, they're really
excited.
good. So we talked a lot about the benefits of the bariatric surgery. Can you describe if there's any potential negative outcomes after surgery that you should be aware of?
Yes, and we're actually going to be covering that in a few slides, so I
Oh,
will
perfect.
come to that.
Okay.
Yeah,
Okay.
yes,
Perfect. So we'll circle back
yes.
on that one. Um, okay, and I think you might have touched on this a little bit earlier, but can you give an estimate as to how much you lose from a bariatric surgery procedure, and does the patient have any control over how much they lose in the post-surgery
Correct.
time?
We're also going to cover that a little bit in the different procedures, but you know, it varies from a patient to another. It varies also with the amount of weight that the patient needs to lose. I see patients with different weight. Of course, I see patients who are 220 and they need to lose 80 pounds to become healthier. I see patients who are 650 pounds and they need to lose weight to be healthier. And as you can imagine, the expectation with every patient is different, correct? And I would tell you, yes, there's ways to make sure that the patients don't lose excessive amount of weight. And I'll be honest with you, it is extremely rare to see a patient losing excessive amount of weight, Yeah. But we have ways to slow down the weight loss if it is too fast. But I'm going to be discussing weight loss when I talk about the different procedures that we perform. Yes.
Excellent. Okay, we'll get more back into that. Just one more question here, just circling back to the kidney stone question. If a
Yes.
patient is prone to having kidney stones and is looking at exploring bariatric surgery, what can they do to help with that hydration, especially after surgery?
So there's a lot of education that we do before the surgery about the amount of fluids that you need to drink after surgery and what to expect and the urination. All I'm going to say is that if a patient is drinking 50 to 60 ounces of water a day, then most likely they're not going to run into trouble with any kidney infections or kidney stones. But patients who are already susceptible to kidney stones, and trust me, I know how painful kidney stones can be. I had my first when I was 19, so I can relate to that. I can tell you that hydration is extremely important. You want to always be flushing those kidneys. So water is the best, of course. You can't see it, but I always have a cup of water. Um, a lot of patients, we're going to see which kind of kidney stones they form. We're not going to get into details into that, but there are 4 or 5 different types of kidney stones, and some patients are susceptible to certain type of kidney stones. So that's something we discuss in the office. Yeah.
Perfect. All right, let's pause there with the questions and let's dive into the second half of the presentation.
Excellent. Thank you all for the questions, and thank you, Kelly. So surgical option, we're going to go talk about the commonest procedures. The idea of a surgical procedure is to help lose weight, and we do that by making changes to the digestive tract pretty much. There are the primary procedures and there are revisional procedures. So primary procedure, one of the procedures that there was a question about is the vertical sleeve gastrectomy or vertical gastric sleeve, or you're going to hear it being called the stapled stomach or just the sleeve. And the idea of that is that we take the stomach and we truly transect part of the stomach. So the stomach itself becomes like a sleeve or like a shirt sleeve. You know, we also sometimes joke about it that the stomach becomes like a banana shape, you know. But what we do is that the rest of the stomach, this part that we detach from the part that's going to stay, we take it out. And so this is the part that stays. And this size is about 150 cc's capacity and, you know, about 5 ounces, give or take. And it's still attached to the esophagus and to the rest of the intestine. So liquids and food will go through this. So they will continue their journey down. Liquids empty the stomach faster. Food will get held back up a little bit. We use stapling devices. These are made of titanium. They are totally inert. Don't worry. They're not going to be setting off any alarms at the airport. They become incorporated. They become part of the tissue. So we don't even have to take them out. And these are like 3 rows of very fine staples. And of course, they're sterile and inert and made of titanium. And then after that, this staple line, I like to suture it again. So this way I think of it as 2 lines of defense so that the patient doesn't get any bleeding, they don't get any leak, they don't get any infection. And, you know, luckily that's been working great for us, you know, and we never had a leak or a bleed from this area. This part of the stomach, the one that we detach, as you can tell with these pictures, now it's no longer connected to the lumen of the intestine. So we cannot leave it there. If we leave it there, it's going to become a problem. So we take this out through one of the small incisions. And when we do the sleeve gastrectomy, it's truly like we do it through 5 small incisions. 4 of them are almost 1/4 inch. And one of them is 1/2 inch. And the reason it's 1/2 inch is because we want to take out the stomach through that 1/2 inch. And yeah, I know it's interesting, but this big part of the stomach will still manage to slide out through that 1/2 inch incision. Now, when we do our procedures, we do all of our procedures with minimally invasive technique, which means it's either laparoscopic or robotic. We put in these tiny ports, small instruments. We put a camera inside the abdomen. We insufflate the abdomen with gas, and then we work while we're looking on the monitor where we can transect and cut vessels and seal things. And there are huge benefits to doing the procedures with the minimally invasive technique, whether laparoscopic or robotic. Of course, as you can imagine, pain is much less with these techniques than having a big wound, big cut. You can also imagine that the risk of infections or hernias in the future is much less. But more importantly, recovery is amazing. And that's why patients are able to get up and walk 2 hours later. 30 years ago, 25 years ago, when we were doing these procedures with an open incisions, patients would be staying in the hospital for a week or 5 days. Pain was horrible and horrendous, and outcomes were not as good, you know. So just by changing the technique, and of course the staplers got better and the technique itself got better, the outcomes got much better. Sleeve gastrectomy is an excellent procedure. You know, it works by, you know, decreasing the amount of food, but more importantly, it decreases hunger sensation. And, you know, one of the side effects of sleeve gastrectomy is reflux. So I tell patients, if you have reflux, again, the best procedure is a gastric bypass. We want to avoid the sleeve gastrectomy in someone who suffers already with reflux. If you have reflux and we do a sleeve gastrectomy, your reflux might worsen. So we're going to consider that as a side effect. Whenever we do a surgery, a procedure, there's always risks of wound infection, whether that is the skin infection or the infection on the inside where we cut the intestine. As you can imagine, inside the stomach and the intestine is loaded with bacteria. The chance of an infection happens when the patient gets a leak or these staples gap. And that's why I was telling you that we like to also suture the staple lines. So as I have like 2 lines of defense, and that's been working great. Bowel obstruction can happen anytime we do a surgery. Scar tissue can form anytime we do surgery. You know, there's always a risks of cardiac events or anesthesia events when we do surgery. So, you know, there's always risks for these things. Now, the chance of having complication as such nowadays is extremely rare. You know, when they looked at the risk profile for a bariatric surgery, Nowadays, when you look at it, it's probably safer than taking out a gallbladder, which is the commonest performed procedure in the US. So that's how safe these procedures are. Now, of course, they are safe because our patients are prepared for the surgery. We see the patients well in advance. We study the stomach. And more importantly, the difference here is that the organ that I operate on, the stomach in this situation or the intestine, is a healthy organ. There's nothing wrong with your stomach or your intestine. They're healthy, they're in good shape. While if I'm taking out part of your stomach because you have cancer, that's a different story. I'm here operating on a diseased organ. While in this situation, I am operating on a healthy organ. So that's why the healing is better and the outcomes are better. Sleeve gastrectomy, as I said, it is a straightforward surgery, excellent outcomes. Patients who do not suffer with diabetes or metabolic syndrome, which is diabetes, hypertension, and high cholesterol, they do great with the sleeve gastrectomy. Recovery is also fast. We said patients are up and walking 2 hours later. Weight loss, on average, I expect patients to lose anything between 70 to 90% of their excess weight, and that varies depending on the amount of weight that the patient is starting with. The second procedure I'm going to mention is the gastric bypass. You're going to hear us call it the gastric bypass or the Roux-en-Y. And, this procedure has been around longest, so we consider it the gold standard of bariatric surgery. As I mentioned earlier, it is probably one of the better procedures for managing diabetes. It is one of the best procedure for managing reflux, honestly. And what we do here is we partition the stomach. So we make a small stomach pouch, then we reconnect the intestine to that pouch. And of course, we need another connection between the intestine and the intestine so that things can continue to drain. So now food and liquids can go down the esophagus, down into that pouch, and then through the pouch, they trickle down into the intestine, and you continue to have absorption. So here you can see that it's not just we reduce the size of the stomach, but we also diverted the food and the liquids a little bit away from part of the intestine. Here we're showing that this is a short segment of the intestine, but in reality, it's longer than that. The pouch is small. It's about an ounce to an ounce and a half. And the length of these intestinal bypasses depends on the size of the patient. So someone who is larger, I'll probably do a longer jump for them. Someone who is smaller, I might do a smaller jump, depending if they have diabetes, their weight, all these things. So that is one of the factors how we control, to an extent, how much weight the patient needs to lose after the surgery. This is an excellent procedure. And, it is probably, again, as I said, best for patients with metabolic syndrome or diabetes or patients who have reflux. Overall, when you compare the sleeve to the gastric bypass, I have seen better weight loss with the bypass. That's overall. But of course, it depends on the patient and it varies from a patient to another. There are other procedures, but these are the main procedures. So these are the ones that I'm going to discuss now. The others we can talk about in the office if there's an interest. But I would say majority of our patients, more than 95% of patients, these are the procedures that they require. One more thing, revisional surgery. So, part of, we said, the complications that can happen aside from the infection, bleeding, one of the feared complications is a clot that can happen in the legs. We call that DVT or deep vein thrombosis, or a clot that can happen in the lungs. We call that pulmonary embolus or pulmonary embolism. Unfortunately, many patients have suffered with these complications during the COVID. I'm sure you heard about it. So one of the ways to avoid these complications is that before the surgery, I'm going to give you a blood thinner, and that's going to be like in the hospital. And then after the surgery, many patients, we're going to calculate the risks for the clotting, and we're going to put you on an oral medication for the next month, which decreases the risk of a clot. And nowadays, that's standard practice in a lot of surgical procedures and medicine. If anybody has unfortunately had a leg fracture, they would know that orthopedic surgeons might put you on a baby aspirin for the next month to decrease the risk of a clot or something like that. So that's also one of the ways to avoid clotting and complications. revisions, I'm just going to touch on that quickly because that is very personalized depending on the patient's situation. We always also do revisional surgery. I've had patients who I had to revise them from a sleeve, convert them to bypass because they have reflux. I have had patients who might have developed an ulcer in the stomach that is non-healing, and we had to revise that. I've had patients who had bariatric procedures a long time ago, and unfortunately, due to a life situation or a social situation or something, they've had suffered with weight regain, where I have to do a revisional surgery for them so that we start weight loss again. So that depends on the patient. There's also complications such as gastric fistula or bile reflux, which are rare nowadays to happen, honestly, the way we do these surgeries. But we still see patients who had their bypasses, let's say, back in 2000, 2005, who have these problems, and we have to do revisional surgery to correct them. So if it is something that you're suffering with or you're interested in, just reach out. We'd be happy to talk to you at the office about the details of revisional surgery. And again, one of the procedures I was talking about is the sleeve to bypass. Unfortunately, when the sleeve started around 2008, 9, 10 even, patients were not being screened well for the reflux. And that's why, if you remember early on, I said one of the things that we always do nowadays before we do bariatric procedure is I insist on doing a contrast study or an endoscopy to figure out if you have any silent reflux. That said, I have had patients who did not have reflux before the surgery, and they developed reflux after the sleeve gastrectomy. Usually, that's not a big deal. They're managed with a medication such as Protonix or Nexium, but it can still happen. And the conversion procedure is a straightforward surgery. It's not complicated or anything as such. Bypass revision also, there's different procedures we can do, whether it is pouch reduction or stromal diameter reduction or distalization of the bypass or elongation of the biliopancreatic limb, and that all depends on the anatomy of the patient. So we might need your operative report if you had it done at another institution, and we do an endoscopy to look at things and study it. Quickly, I'm going to just talk about St. Agnes. St. Agnes Hospital, we've been doing bariatric surgery at St. Agnes Hospital since 2001. It's always been one of the leading hospitals in bariatric surgery in the state of Maryland. We have, at this point, trained 22 surgeons who have gone on and participated in bariatric surgery and are practicing bariatric surgeons all around the world. So that is one thing that we're very proud of at Ascension St. Agnes, the bariatric surgery program and the support of the hospital to the program. We have our specialized operating rooms. We have our specialized operating room teams that help us with the journey and the procedure. We have our bariatric surgery floor that's 3 South in the hospital, where the nursing staff is trained in taking care of bariatric patients. And all of that is important. To have good outcomes, you need to have the entire team that is, trained in bariatric surgery, knows what to do, knows how to support our patients. Because when I tell you it's a journey, it's truly a journey. I joke with my patients, but after the surgery, we're going to be seeing you 2 weeks after the surgery, 6 weeks after then, 3 months after that, 6 months after that, and then hopefully every year we're going to be keeping close eye on you. So it's going to be a strong relation, to support you throughout this journey. And the team, of course, you have the surgeons, you have, of course, the first member of the team. I always joke, is the patient. Without a patient, then there is no team. So the patient is going to be the leader, because every patient is different. Every one of us has our own story. So that is important to understand and relate to. You have the surgeons, you have the nurses, we have our physician assistants, the PA. We have 3 patient care navigators in the office who will help our patients throughout the process with the insurance company, with setting them up for the surgery and, getting the date for the surgery, all that process. We have the nutritionists, the social workers, the psychologists, and the office staff. So it's a big team, but of course, the most important part of the team is the patient, and patient being motivated and doing following the steps. So that's why I feel like it is the most important step for us as a team is to prepare the patient before the surgery. If we do a good job, then your journey is easy. There are no surprises after the surgery, and the outcomes are good. All right. Thank you, Kelly. I'm going to stop here and see if there's any questions. Sorry, I ran a little bit over time.
Oh, no. That's all good. That was a lot of great information. Thanks for sharing that with us. We do have a few questions to jump into. Um, if you have bariatric surgery and you lose a significant amount of weight and develop excess skin, how is that handled after the procedure? And is that something that insurance typically covers?
So, it depends. Sometimes insurance covers the abdominoplasty part or the panniculectomy, they call it. So as long as there is hanging skin and it shows that it's causing, difficulties with daily life activities or there's skin irritation, some insurance companies cover it. I cannot really speak about, the full coverage because I personally do not do these procedures. Usually in the state of Maryland, we have specialized plastic surgeons and cosmetic surgeons who do that. There is a core group of surgeons who have done wonderful work with our patients. As you can imagine, uh, we have good experience with it because we've been a busy program over the last 24 years. I cannot tell you how many patients we've taken care of so far, but it's probably close to 10,000 bariatric patients. So we've seen good outcomes from certain plastic surgeons that we can guide you and help with the process.
Great. Will bariatric surgery affect irregular menstrual bleeding related to PCOS?
Excellent question. So the answer is yes. We've seen patients, I've had patients who haven't had a cycle in years, and after the surgery, they had the cycle because the PCOS hormonal levels improved with estrogen and progesterone, and they had a period. Many times, the first month, if the period happens while the patient is on the blood thinner, it might be heavier. But then after that, it regulates. So I would say overall, I expect the menstrual cycle to become more regular. The first month, it might be heavier because of the blood thinner if I put you on a blood thinner. But one of the important things is with the PCOS is the infertility fertility, because I have several patients who were infertile, and because of that, they haven't used, let's say, contraception after the surgery. And as I said earlier, we don't want you to get pregnant the first year and a half. So, it's something important to focus on. It's because I've had some patients who got pregnant early on because they told me they've been infertile for years, and then all of a sudden, I joke about it. It seems like it is the 3 to 6 months mark after the surgery. Patients lose weight, and all of a sudden they're very fertile. By the way, surgery and losing weight improves, erectile dysfunction in many gentlemen. Also, that's important, and the sexual activity improves. So, yeah, we'll talk about that more in the office.
Perfect. Thank you. Has there been any correlation to an increase in alcohol-related diseases after bariatric surgery?
Yes. So with the alcohol, there's alcohol dependence, and that's an addiction. And there are some patients who have addiction tendency, whether it is through the food, through smoking, through alcohol. So there is some, dependence transference or addiction transference that we've seen with some patients where it becomes alcohol is a problem. So that's why part of the counseling with the social worker or the psychologist before the surgery is going to be counseling about that part.
Perfect. Thank you. Can patients try GLP before exploring surgery through your office?
I personally do not prescribe it, but we work closely with a few physicians, providers who prescribe GLP-1. And, especially for patients with higher BMIs, we have seen some benefit in them going on a short course, like 3 months to 6 months of GLP-1.
Perfect. Thank you.
But we can guide you through the process, yes.
Excellent. With the bypass, what happens to the excess stomach?
That's an excellent question. It's the difference between the bypass and the sleeve. Let's look at this illustration here. With the sleeve, because the stomach is totally detached, so we have to take it out. Well, with the bypass, the rest of the stomach is still connected to the intestine. So this continues to function. It secretes, hormones and enzymes and fluid and acid that will drain through the rest of the intestine. So it is functional. It stays there. It's totally detached. And if I ever have to reverse the bypass and take it down, it is possible. I've had to do that at least 4 times. Most of the patients I had to do that for them, it was either someone had a car crash and they lost a lot of weight, so we wanted to reverse it. I had another 2 patients who were excessive smokers who had an ulcer, continued to smoke afterwards, so we had to reverse their bypass. But yes, bypass is reversible and that part of the stomach stays there and it's functional.
Excellent. Thank you. Is there any particular kind of food that you should avoid or may not be able to handle eating after you've had bariatric surgery? Not necessarily immediately after the surgery, but like down the road, like a ways after the procedure.
The biggest thing is down the road is dumping. And dumping is a process that can happen when you have a high sugar content all of a sudden sneaking down the intestine. It can give you a terrible feeling. Dumping happens when a patient would eat something that is high in sugar. So especially early on, ice cream can cause dumping. So we want you to avoid ice cream, something like that. So I would say food that has high sugar content. That said, down the road, yeah, I do want you to enjoy a piece of chocolate here or there, a small piece of cake here and there. So all of these things are fine.
And is that
But,
just
alcohol, again, in moderation, I tell patients first 3 months, no alcohol. Then after that, a glass of wine here and there should be fine. Smoking is a no-no, of course, no-no before surgery or after surgery. So that's something to totally avoid. Yeah.
sure? And the dumping, that term does that just mean an elevation in your blood sugar level, or does that actually mean like regurgitating or in some other way getting rid of the food?
Excellent question. So the medical definition of dumping is actually the elevation in the sugars, where the body responds by having a high insulin surge, and that causes patients, gives them like vasomotor or symptoms, and it can even cause diarrhea. But the common term now, dumping, is used more so for, I ate something that rushed through my intestine, gave me a bit of upset stomach, or even sometimes it might be vomiting. So, it
Could be really.
varies. Like this is one of those, it's the same thing as when you say dyspepsia. It changes from one person to another, the definition. Yeah.
Gotcha. Thank you for clarifying.
Thank you.
So when a patient, like what would be kind of the first step for starting this process? Would it be scheduling an appointment with your office or reaching out to their primary care physician, or kind of where would the best place be to get the ball rolling?
So usually it's good to discuss this with your primary care physician. Definitely get a referral from your PCP if your insurance company requires that. And most insurances in Maryland require you to get a referral because we're a consultant service. And then give our office a call. Tell them that you did watch the webinar. You can also even watch the webinar again online when you go to our website. But you can just call the office. They can set you up with an appointment. We can sit in the office, review your medical conditions, your situation, and come up with a plan from there. Yeah.
Perfect. And the part of that process with talking with your office is determining the best procedure for that particular patient.
Excellent. Yes, yes, of course. And the majority of patients are excellent candidates for any procedure, but that's why we need to personalize the treatment to every patient. Yes.
Sure. Excellent. Well, I think that is the end of our questions that we have in here right now. Um,
Excellent.
Excellent. So if you do think of any additional questions or you'd like to get more information, you can reach out to Ascension St. Agnes Bariatric Surgery. It's Dr. Hamdallah's office at the number on your screen, 667-234-8725. Or you can also find more information on mdbariatrics.com.